Hello, everyone. Thanks for joining us for this Part B Cardiology Common Rejections and Denials webinar. This webinar is designed for those providers who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Moko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your speaker today, and assisting me is my friend and colleague, Ellen Barra. We include this disclaimer in all of our education, and we do so to remind learners that although we made every effort to make certain the information we provide is current, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And just one last reminder, CMS prohibits recording of this presentation for profit-making purposes. We are recording this webinar and it will be available later on our YouTube channel and on our Encore Presentations webpage. Now, when you registered for this event, you may have noticed in our advertisement that our agenda shows that this presentation today really focuses on data. In their internet-only manual, it's Publication 100-09, Chapter 6. CMS instructs that MACs should analyze and provide education on claim submission errors. Claim submission errors include those that result in rejections or denials. We have to maintain a provider data analysis program that shows a monthly list of the most frequent collective claim submission errors from all providers in our jurisdiction. So that's why I am offering this series of webinars to focus on common rejections and denials for various specialties. So for today's webinar, then I advertised that during the next hour I spend with you, I'm going to discuss data for specialty 06 providers. Topics that I said I would cover include common rejections and denials. I'll be identifying those for you, ways to fix them and avoid them. And I'll also provide many helpful resources that's going to really help you fix and avoid the rejections and denials that I plan to talk about today. Finally, I advertised that I would answer questions about those common rejections and denials. To fully understand rejections and denials, it's important to recognize the path that a claim takes, and we call this the life of a claim. Here is a simplified graphic on how a claim gets into our processing system. The service is provided, a claim is submitted. The system may reject those claims if something's not right or if the content for the claim is not correct. When that happens, a 277 or 990 report is generated to help explain why. So this slide then really describes claim submission, and most providers submit electronically. Very few providers qualify for a waiver under a law that prohibits payment of services or items that were not submitted to Medicare electronically. Now, to confirm claim receipt, providers should use the 999 report. Providers use the 277 report for more specific information, and our electronic data interchange or EDI staff really provides some helpful information. It's available in what is called the Medicare 277 companion guide, and I'll show you where to find those a little bit later in this presentation. These companion guides are really going to help clarify and further define data content requirements for an electronic claim, and it is based on these reports that you will know if the batch is rejected or if you need to correct or resubmit the claims. Here then is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. Unprocessable is simply another word for a rejected claim. And it's really very, very important for everyone, providers, billers, coders, and those of us that work for Medicare or work for CMS to really recognize that a rejection is a very different thing than a denial. Rejections, as you can see on this slide up on the left-hand side, are unprocessable. They're returned on the front end. The claim does make it into our system. However, something's missing or illogical, something's incorrect, so the claim is returned to the provider as unprocessable or rejected. For these claims, rejected claims, there are no appeal rights. What you need to do is resubmit the service. There is a remittance advice remark code, MA130, that will appear on a rejected or on the remittance notice for a rejected claim. And basically what that does is inform the provider that the claim includes incomplete or invalid information, there's no appeal rights, and that you need to submit a new claim with the complete or correct information. On a rejected claim, on that remittance advice or the remittance notice, you'll also see the C016 group code. This means it's contractual obligation, and that means that you can't bill the patient. You need to fix and resubmit that claim. Now, unlike a rejection, a denial or a denied claim is adjudicated, and it is something's denied because it doesn't meet payment criteria. Now, this could be based on law. You'll see that full bullet there. First bullet there says statutory requirements. Perhaps the claim denies or claim line denies due to medical necessity, and this would include any utilization parameters or frequency guidelines. And also claims may be denied due to eligibility. It could be the provider's eligibility, or it could be the beneficiary's eligibility. For denied claims, with very, very few exceptions, appeal rights are available. And when you look at your remittance notice for a denied claim, you will see MA01, and that is the remittance advice remark code that states if you don't agree with the decision on this claim, you have the right to an appeal. And for denied claims, of course, patient liability or patient responsibility would be determined. This graphic shows the path then for a process claim. The service is provided, it's submitted to Medicare, and either the claim pays or denies. And of course, a claim could partially pay. Some of the claim lines may pay, some may deny. But at any rate, when a claim is processed or adjudicated, the remittance advice is generated. I want to talk about the remittance advice just for a moment. Sometimes we refer to this as the remittance notice. Some people just simply say remit. Some people call it the RA. Most providers are going to receive an electronic remittance advice, that's an ERA, as opposed to a standard paper remittance or SPR. Now, depending on how the claim processed, the RA may include information about adjustments that were made to the claim or denials. It could also include information about things that could be missing. Sometimes it even provides notice about refunds and offsets. And the ERA then provides payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank. When you're looking at and viewing the remittance advice, you'll see various codes, and these codes on the remittance advice provide information about the claim. Claim adjustment reason codes, or CARCs, explain why a claim paid differently than it was billed. And a remittance advice remark code, or RARC, provides more details about an adjustment that's described by a claim adjustment reason code. Another type of code that appears on the remit is the group code, and these convey the financial responsibility for that unpaid portion of the claim balance. A CO stands for contractual obligation. That means the provider's liable and you can't bill the patient. A PR means that the patient is financially responsible. You can find code lists on the Washington Publishing Company's website. They are the contractor that maintains these codes for CMS. Now, I do want to mention to you that we understand that some of those codes may be cryptic or maybe even out of date, but And an example of that is that some of the code messages may include, for example, an outdated acronym. But you can find the code lists on the Washington Publishing Company's website. I know from time to time we get requests from providers to change one of those code descriptions that appears on the remit, but WPS can't do that. If you have a suggestion to make for changing those, you do need to go to the Washington Publishing Company, and there's a link to their website on this page. Now, after reviewing the remittance advice, you are going to need to choose an action. What are you going to do to fix or correct that claim? And for an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim to Medicare. So if the claim or the claim line denied, there may be or could be multiple actions to choose from. You may be able to simply resubmit the claim or the service. You might be able to use the clerical error reopening or CER process to fix clerical errors, and CMS defines these, those that include minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk more about this clerical error reopening process in just a couple of minutes. Another action to consider is an appeal. The remittance advice will provide those appeal rights with few exceptions. Like I mentioned, there are rights to an appeal when a claim line or claim is denied, and I'll discuss appeals just a little bit later also. Registered users of our transactional portal may render a clerical error reopening or request an appeal using that transactional portal. Now, these self-service tools, such as the transactional portal, really do offer the most efficiencies. We have a portal user manual that provides both illustrations and step-by-step instructions on how to use the portal features. So you'll find that handy. And when I go out to the website in just a little bit, I'll point out where you can find that portal user manual. Now, after reviewing your remittance advice, as I mentioned, you'll have to choose your action. There is a great deal of information that appears on the remittance advice. I don't have time to go over all of that during today's presentation. I want to identify those common claim rejections and errors. But if you're interested in more information about the remittance advice, I've included a couple of very helpful resources right here on this slide. Next, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. And this is now the time when I want to talk about this particular process called the clerical error reopening. This is that process to correct human or mechanical errors, and clerical errors or minor errors are limited to errors in form and content. The final bullet on this slide includes a link to a helpful resource that appears on our website. I like to point this out whenever I talk about clerical error reopenings because it does a really good job of explaining what is an acceptable clerical error submission versus what is not. So, for example, some of the acceptable clerical error submissions could be mathematical or computational mistakes, maybe a transposed procedure or a diagnostic code. Also, inaccurate data entry, maybe misapplication of a fee schedule or other computer errors. These are all examples of acceptable clerical error submissions. And of course, it also, that resource there that's linked on your handout includes those situations that are not acceptable clerical error submissions or reopening submissions. Remember that, or I should say, you can use the clerical error reopening functionality on our transactional portal, but you can also request one via telephone or fax. And remember that that portal user manual provides instructions for all of the functions or features of the transactional portal. I do want to provide just a little bit of information or a little bit more information about appeals. Of course, we have, a lot of information both on our website and out on our YouTube channel that pertain specifically to appeals, and I can't talk about them all today in this 1 hour, but for most claim denials, you can request an appeal. There are 5 levels of appeal, with the first level being called the redetermination, is the only one that's rendered by the MAC. And the purpose of the appeals process is really to ensure the correct adjudication of claims. Now, physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by the MACs. The beneficiary or their representative can actually request an appeal on any service process for them. Providers and suppliers can appeal services for which they accepted assignment. However, for unassigned claims, providers or suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement. One example of this would be the CMS 1696 appointment of representative. Now, in addition, providers or suppliers can request a redetermination on an unassigned claim if Medicare denied the service is not reasonable and necessary, or if the provider or supplier billed in excess of the limiting charge. And in that case, the provider or supplier would need to refund any fees or any amounts over collected from the beneficiary. As I mentioned, there are 5 levels of Medicare appeals. The first level is the redetermination. That's the only one that is rendered by the MAC, like WPS-GHA. Time frames or time limits actually appeal to each of those 5 levels when you were submitting a request for an appeal. Similarly, whoever is making the decision on that appeal request also has time limits for completion of that determination. There are amounts in controversy or minimum amounts that apply to levels 3 and level 5, and you can combine like denials on more than one claim to reach that threshold. All right, now we talked about the definition of rejections and appeals and how they're different, and it's important to notice that. The next portion of this presentation includes a discussion of the data that I used to provide most common or common rejection denials, specifically for specialty 06. So the data that I'm sharing today, sorry about that. The data that I'm sharing today is all specialty 06 submitted claims for jurisdictions 5 and 8. Those are WPS-GHA's MAC jurisdictions. So that means all of the states of Iowa, Kansas, Missouri, and Nebraska, that's jurisdiction 5, or what we call J5, and Indiana and Michigan, what we call J8 or jurisdiction 8. Now, while the dashboard allows us to drill down by a specific state and even counties, the data that I pulled is for our entire jurisdictions. For those of you that may be wondering what specialty 06 is, I've mentioned that a couple of times. It is a 2-digit code that's assigned to WPS-GHA providers when they enroll. During enrollment, providers self-designate a specialty. While a provider can designate a secondary specialty, it is only that primary specialty, that self-designated specialty. CMS provides 2-digit codes for all of them. That one designated is the one that is used during initial claim processing. Sometimes there may be situations where a provider wishes to change his primary specialty, and you would need to contact provider enrollment or use the PACO system in order to do that. There are some situations where a provider will request an appeal and they'll stipulate their secondary specialty in order for Medicare to make payment. There are just a few situations like that, and that might apply to you. So I pulled data for claim submission dates October 1 of 2023 through March 31 of 2024, and the data was last refreshed on April 10 of 2024. So what this means is that any claims submitted for this date range after April 10 are not included in the data that I pulled for this presentation today. So here then I am revealing, if you will, common rejections by reason based on the data that I pulled for today's webinar. The number one reason for rejection for cardiologists in our jurisdictions is that the claim lacks information needed for adjudication. This would be a situation where you'd want to look over the claim and make certain that everything has been submitted. You know, if you are billing for a service that has some questions for coverage in a local coverage determination, and it says you need to put XYZ on the claim, that's exactly what you need to do. The information needs to be provided on that claim. And if the claim lacks that information needed for adjudication, it's going to reject. 4,625 claims within that time frame of data. Another rejection for cardiologists is that the rendering physician number was invalid or missing altogether. You would, of course, need to submit a new claim. These rejections that I'm showing you right here reflect the actual denial message, or reject message, I should say. There I am, I'm mixing up rejections and denials, and I shouldn't do that. And this one is interesting, I find, and I always point this out when I do these presentations. The first word is denied, but really what we're talking about are rejections right now. We can't change that denial message that appears on the remittance advice. That would be up to that Washington publishing company, but it does say denied, although this is a rejection. So what you need to do here then is make certain that the rendering physician number is there, or that it is valid. Another claim line shows based on data, and it's almost exactly the same as reason one, but the claim or the service lacks information needed for adjudication, 1,167 claims. The next common rejection based on the data I pulled and analyzed is missing, incomplete, or invalid ordering primary identifier. So this means that typically it's missing, it's not there at all on the claim. You would need to submit a new claim that includes the complete or valid ordering primary identifier. This means that for that service that was billed or reported on the claim, it requires an ordering provider, and in this case, the identifier for that ordering provider was not there. Next one, the hospital should bill Part A for this service, 549 claims. There are certain services that should be billed professionally, and certain services that need to be submitted by the facility. And if your claim line is denied, or it says you need to, the hospital needs to submit for the service, then the hospital needs to do so in order for Medicare to consider payment. The next one, claim must be submitted to another contractor. This could be a situation where another MAC is responsible for paying that claim, or another contractor type. Let's look at more rejections. Patient, insured, HICN, and name do not match. Here's one of those situations where I mentioned to you that some of the denials are outdated. Those reasons that print out on the remit. We no longer use HICN, the health insurance claim number. What we're using now is the Medicare beneficiary identifier. This means that the name on the claim form does not match what the name shows in our claims processing system, or in the edits that are used by the MACs. If your patient's Medicare card shows a middle initial, you need to put the middle initial on the claim. Then that's what this reason, or this rejection is. The name on the claim and the name do not match, or the name in our systems does not match. Next common rejection, claims should be sent to the UMWA for processing. That is United Mine Workers of America. In this case, it would be a patient with black lung, or being treated for black lung, and those claims are processed by UMWA. Facility lab name and address missing from the claim is 108 rejections. You know, a lot of these rejections are really explanatory. In this case, the facility or lab name and address or PIN was missing from the claim. You need to add that information and submit the claim to Medicare. The next common rejection, place of service conflicts with procedure codes. What this means is that the procedure code reported and the procedure code reported is not valid for that particular place of service that's reported on the claim. You need to fix that and resubmit a new claim. If you ever question, does Medicare allow payment for CPT code 12345 in place of service 12? You can ask that type of question to customer service. However, what you can't do is provide a scenario and ask them to let you know if you can report a particular code with a particular place of service. That's considered coding advice, and CMS prohibits the MACs from offering coding advice. So, you need to keep it real simple and straightforward and say, will your system accept this code with this place of service? All right. Next, common rejection or unprocessable is denied. There's that denied word again, even though it's a rejection. Description of service missing, submit a new claim. And finally, the last of the common rejections that I analyzed and pulled was that the claim has been forwarded to Palmetto, and you see RRB there in parentheses. RRB stands for Railroad Retirement Board, and this means that WPS has forwarded the claim already to Palmetto. They are the railroad retiree contractor or retirement board contractor, and they will process the Medicare claims for that particular Medicare beneficiary. Similarly, sometimes some of the common rejections are that your claim is rejected, you have to submit it to Palmetto. Sometimes we, WPS, will do that and forward the claim to Palmetto. Sometimes the provider needs to do it himself or herself, and it depends on those trading partner agreements we have with those supplemental insurers that appear on the claim. All right, I thought it would be interesting to not only look at the reasons for denial, but I thought it would be interesting maybe to do if I provided for you the common rejections by HCPCS and CPT code. Now, these are the codes then. These are the most commonly rejected codes. These are the ones for those reasons I just talked about. The reasons why this set of HCPCS or CPT codes was rejected. You can see on this list, EKG interp, we have the implantable, insertable cardiac device evaluations. That G0463 is a code that the hospital should bill for. So that was kind of a heavy hitter with 549 rejections. And you can see there also the 99213 is an E&M, 205 rejections for that particular code for all of those reasons I just mentioned previously. Collectively, these are those most commonly rejected HCPCS codes. Now, the data analysis tool that we use is a dashboard, or one of the tools we use, I should say, is a dashboard that our Insight team has created for us. Insight is the department at WPS-GHA that pulls data. They're the data informatics folks, if you will. They created this dashboard so people like Ellen and me can go out and pull our own data. We can actually break down also the reasons why these particular codes denied, but I really just kind of talked about that collectively in the last few minutes, those most common reasons for rejections. All right. Here then, we talked about rejections. I also advertised I'm going to talk about common denials, and here are those common denials by reason. Collection of fee for service during periods of managed care. 9,055 claims came in, or claim lines were denied by WPS-GHA during the time frame that I identified because the patient had Medicare Advantage. And the services shouldn't have been processed by or received by WPS-GHA. So that's kind of a heavy hitter, not just for cardiology, but for a lot of the other, so far, the other specialty codes that I looked at. And just to to bag you up, I haven't done a whole lot of these yet because we're now at specialty 06. I started with 01, so this is the sixth webinar then. But this one's hitting for a lot, and what you'll need to do here is, make certain that you're checking eligibility for your beneficiaries so that you know where that claim needs to go. Does it need to go to the managed care plan? Does it need to go to the railroad board? Does it need to go to home health and hospice? So on and so forth. So eligibility in totality is one of those heavy hitters reasons for claim denials. Another very common denial, not just for cardiology, but for a lot of specialties across the board. And for 20 years, I've been in provider outreach and education, and for 20 years, I've been talking about this reason for denial: duplicate charge. Your remit may say this is a duplicate charge. It could say duplicate charge paid on such and such date for this claim. And that's what these question mark and numbers and X's show. The question mark 002XX stands for a date, and then the next one, the question mark 001 with the 10 X's, stands for the ICN on the claim. So that's what you'd actually see if you were seeing this on advice. There's also duplicate charges of claims that are in our processing system at the same time. So you might see a denial on your claim, such as the fourth bullet: duplicate charge of claim now being processed. For the first duplicate, there was over 6,000 denials. That fourth bullet, over 2,300, and then on the fifth bullet, another over 2,300. And if you think about each one of these denials as a claim, perhaps, think of the cost to both the provider and to Medicare. We're spending a lot of money submitting claims to Medicare for duplicate charges. You are, the provider community, I should say, and we, Medicare, is spending a lot of money processing those denials for duplicate charges. So, make certain you're checking, double checking to see if you've received payment. If you use a billing service and the billing service automatically submits claims on a 30-day basis, tell them to stop doing that. It's actually considered abusive. You shouldn't just automatically resubmit claims on a cycle. It's not appropriate. It's considered abusive. So just a lot of claims being denied for duplicate reasons, or as duplicates. The middle one there, payment included in another service received on the same day. That's a bundling type edit. So you'll need to look at two services to determine if they can actually both be billed and both receive payment. Maybe it's a situation where you need to append a modifier to one of those claims. It could be a situation where there is a code pair edit in place, and you can learn about the code pair edits and the National Correct Coding Initiative edits out on the CMS website. I did include the links to those procedure-to-procedure edits as a resource when you look at your handout, and we'll be talking about those resources in just a little bit. So another thing that you consider is if the payment's included in another service day, it could be that you're submitting a CPT code or HCPCS code for a service that's bundled. For those that are bundled and always bundled, and what I'm talking about here is on the relative value file, and I've included the link for that resource, there's a status column for each code on that file, and it's available on CMS's website. If the status code is a B for a particular CPT code or HCPCS code, that means bundled. It's always bundled. There's no way that your Medicare is going to make reimbursement for that service because payment is included in another service received on the same day. Let's take a look at more common denials. Medicare does not pay for this service in this facility, 1,941. Going to make sure that you're billing your place of service correctly here. Take a look at the service that you're billing to see if it is one eligible for payment in the place of service that you're submitting. The second bullet there is just yet another duplicate denial. Next, the physician is not eligible to receive payments. For this one, you're going to want to contact provider enrollment and make certain that the eligibility date or the dates on the file for the physician or supplier is accurate, or it might be that the date of service on the claim was not correct. A couple situations there, because this denial is when the physician or supplier is not eligible to receive payment. Denied service or units of service are exceeded. This one, I would go to the medically unlikely edits that are published on CMS website, also part of the National Correct Coding Initiative. This means that you build units of service in excess of the medically unlikely edit published number. Not all of the MUEs are published. Some of them are confidential due to potentials for fraud and abuse, but most of them are actually published, and you will need to follow those. If you bill units that exceed the MUE, it is appealable. You could submit your documentation or request an appeal using our transactional portal and provide the documentation that justifies why the units of service exceeded that MUE. Next common denial for cardiology is the time limit for filing your claim has expired. You have 1 year from the date of service to submit your claim. When a claim is denied based on timely filing, there are no appeal rights, and that actually prints out on the remittance notice. For this situation, I have included for you in the resources in your handout materials a link to an article that appears on our website that tells you if you would like to request a waiver for timely filing because the time limit has expired. You need to send certain items to the claims manager. So this resource that I placed the link to in your handout tells you step by step what you need to do. One of the questions on the when you registered, we asked you, if you have a question on the topics that we're going to talk about. One of the questions there that really does our presentation specific or pertains to what I'm talking about today was timely filing denials. And the question was, does Medicare ever make a payment or ever waive that timely filing requirement when there's a third party involved, like another insurer that may have initially paid and later came and took back money and now you want Medicare to pay? The question is, yes, Medicare may make payment for those situations. However, it's not very frequent. There is some specific language that CMS provides to the MACs or instructions to the MACs about waiving, whether or not we can waive timely filing when it pertains to those third-party situations. And we've actually included that language out in that resource that's on our website. So I did want to mention that since someone did put that on their registration. For those of you that submitted questions about topics that I'm not talking about today, I did send out an email earlier this week to tell you that this information is not being presented today during this webinar. What I've done is added all of those types of suggestions to the list of topics we can consider for future webinars, or I provided in that email a link to where you can find information. And finally, if you have a question about something that I'm not talking about today, you can pick up the phone and give customer service a call, and someone there should be able to help you by responding to your question. And again, I'm talking about those questions about topics that I'm not talking about today, rejections and denials. All right, next on is expenses incurred prior to coverage, 1,153. Again, this might be a situation where the date of service could have been transposed when it was billed, if it really was payable or provided after coverage. So in that kind of situation, you would need to check your documentation, check how the claim was submitted. Was it correctly submitted? Should Medicare have paid the service because the date of service is wrong? You would need to request an appeal. The final common denial by reason for 06 provider types is that the claim must be sent to EGHP or LGHP first, and that's an employer group health plan, or I just completely escaped my mind, LGHP, another group health plan first. I can't remember right now, and I'm sorry what the L stands for, but these are situations, or to fix or correct this. This is a situation where there's a Medicare secondary payer situation, and for that particular beneficiary, based on the information in our common working file, there was someone else that should be responsible for primary payment of that claim. So this just tells you that you have to send that claim to that other health plan first before Medicare can pay, and that's why we denied it. There's a lot of great resources available on our website, on CMS's website, that pertain to Medicare secondary payer. And I think the one that I actually chose to put into your handout are Medicare secondary payer questions and answers, because it kind of covered everything from A to Z that pertains to Medicare secondary payer. And I do want to let you know that our YouTube channel has some great videos that pertain to Medicare secondary payer. So again, a lot of great resources there for you. Here are the most commonly denied HCPCS and CPT codes for those reasons I just talked about. No big surprises here. You have the EKG interp. We have the 93306, and I think I actually looked at why that particular code was denying, because I wanted to know specifically. This one was denying for different reasons. One is that the beneficiary is on a Medicare Advantage plan. Another reason this code denied so often is that for duplicate reasons. Another was the Medicare secondary payer situations that I just talked about. And another heavy hitter for this one was that the units of service exceeded the MUE. So just to give you a heads up. I do want to point out the G1004 that appears on this this list of common or most denied claims. The reason this code is hitting here on most common denials is that this code is used for reporting purposes. This is the clinical decision support mechanism, decision support company, as defined by the appropriate use criteria program. So it's really just a reporting code. It's giving information, so it denied, but we recognize that it correctly denied. If we're looking at and analyzing denials, we're not going to say, oh, wow, you know, there's 1,400 claims denied for this. It's supposed to. It's a code that's placed on a claim, and it's for reporting purposes only. You can see the 99204 there. I looked that one up, and no big surprise. This one is hitting only one initial visit per specialty. So for this one, you would look to your evaluation and management guidebook, and I have that as a resource also. So, and just to go back to the appropriate use criteria program, CMS did continue that program, but for that time period, for those claims submitted, for those dates that I told you about earlier, that I pulled for this webinar, at that time, a lot of providers were still reporting that G1004 on their claims. But CMS has done away with that. At this point, as we understand it, there's no plans to start up that or continue with the appropriate use criteria program. Of course, that could change down the road, but as of right now, CMS has stopped it, halted it. As I mentioned, there's a lot of data available that we can pull. Obviously, for those data pulls where we're looking for information that we can't get on that dashboard that our Insight staff created for us, we can actually send a request to the data unit for them to do the data pull. But we can break down data a number of ways. They're listed here on the slide, right down to the county. I know sometimes when I do a presentation for a specialty group, what I like to do is to pull claims from the counties that surround the city that I'm speaking in. because that makes sense. I want to get the information to those folks that where it's applicable. So if they're coming from the surrounding counties, I want to give them their data. We can also look at trending, and I want to show you an example of that. This is data trending for denials for that same report period. This says there were 44,149 denials for the 3 months prior to my procedure or my data pull. For the current 3 months, though, there's 60,955. So what this tells me when I'm looking at it, it's trending. It's trending up. Our denials are trending up. And this is the type of information that CMS wants us to look at and figure out what we need to educate on in order to avoid those in the future. So here's a good example. This one that I pulled from a trending report is for charges incurred during an incarcerated period. Current 3-month count is 159 claims. Prior 3 months, only 61 claims were denied for this reason. The difference in the number of claims is 98, and the report shows all of this. The percentage change is 161%. And then by looking at this report, I could see all kinds of red and green arrows, red going up and green going down. Of course, what we want to see for data trending is we want to see denials decreasing, not increasing. So here then, this would tell me that, well, maybe there's a need to do some education on this. Okay, so that's exactly what CMS is looking for. The next portion of this presentation focuses on the tools or resources that you can use either to fix those rejected claims or to appeal your denied claims, or better yet, to avoid them altogether. So here are those requirements for Medicare claims. This in Chapter 26 of the Claims Processing Manual is the completing and processing Form CMS 1500 data set. And this tells you item by item on a paper claim form what needs to go there. Is it required? Is it situational? Let me look here and pull over the CMS. I'm going to go to CMS's webpage. If you scroll down when you're on the CMS webpage, you'll find manuals, forms, and transmittals. This is where you can find the internet-only manuals. And this is the claim processing manual that I'm talking about in Chapter 26. And you do have the links for these, and they're all spelled out, but I want to show you real quick what it looks like. And this is the completing the claim form information. Item number 1, this is what you need. Item number 2, this is what you need, so on and so forth. But we all know that most of us don't use paper claim forms anymore. We use electronic claims. So what goes where? Well, this particular item here, this crosswalk, is a document that was created by our data team. And if you're on the WPS website, under quick links, go to EDI, Electronic Data Interchange. You're going to scroll down because you want to choose on the left Medicare EDI. We also have TRICARE in our commercial insurance. But under Medicare EDI, these are those reports that pertain to electronic claim submission. I talked about those companion guides early on. These are what tells you the data content that's required for submitting claims into WPS. Here is this crosswalk that I'm linked to on the slide you're looking at. And this is the crosswalk from the paper form to the electronic form. So if it goes in item number 1 on a claim form, here's where it goes then on the electronic form. This is what's required. You'll notice this status column. Sometimes there's an R there, sometimes there's an S. If it says R, that means it's required. That data element must be on that claim in order to process a claim. So again, going back to those reasons such as, something's missing, we can't adjudicate your claim. This is the kind of information that could be helpful to you. Those that have S's are situational, and those are explained at the bottom of each page. This needs to be completed if other conditions exist, so on and so forth. One that I can think of is item 19, that kind of catch-all area, catch-all box or item. If you build a not otherwise classified code, you need to put the description of what you're billing in that box. That crosswalk tells you what to put where. How to correct a rejected claim is a resource on our website. It's listed by remark codes. So those remark codes that appear on your remit, if you look at them here, and this resource on our website, it will tell you how to fix it or how to correct it. Similarly, we had rejections I just talked about. Now I'm talking about denials. We list denials or how to fix them by reason and remark codes for categories. We have the bundling category, entitlement denials. We have duplicate claim denials, global surgery denials. So again, we list by those reason and remark codes that I talked about earlier, specific to these categories that you see here on this slide. That is our resource for claim denials. Website, here is that link to those MSP Q&As. Our live events webpage to registration for upcoming events, our encore presentations, our recordings of our webinars. The LCD lookup tool I would like to show you. Pull this over here. On the homepage of our website, we have a code lookup tool. You can look up LCD and article matches, or you could do a search for the NCD lookup. So for example, I'm just picking any code just as an example and searching LCD and article lookup to see if that code appears in the coding article that goes with any LCD. When we're looking or searching for LCD, it's going to search only the title of that LCD. And since we can't put codes into LCDs, they have to be in that article, that companion document. Obviously, if you put a code in here, you're not going to get a match in LCD, but you could get a match to an article lookup if the code appears in an article. Just keep that in mind when you're using codes to look up. You might want to just use a word or a part of a word. Oh, I spelled it wrong. It helps if you spell correctly. You know, if I wanted to look up any LCD or article with psych in it, I could put that here in the box. And of course, that wouldn't pertain to cardiology that we're talking about today. But this would give you the LCD or the coding article that it matches. All right, so that is the lookup tool. YouTube channel has a lot of great playlists. Provider enrollment guides and resources. Remember, if you want to change your specialty, or if there is a, if you build a service before the provider was eligible, you'd want to be looking at provider enrollment. We have MSP, and here is the timely filing of claims. And I just wanted to show that because I did get that timely filing of claims. I just searched timely. I'm a searcher, not a navigator, so you see me going to the search box a lot. So timely filing of claims is here. I mentioned this code earlier and told you that someone submitted it, pre-submitted it before the webinar. This is that section or that language that speaks to those claims not filed within time limits due to third-party errors. And this is what CMS says in our internet-only manual. You'll see the italicized language. That means it's CMS language. And I provided a link to Chapter 34 of the Claims Processing Manual, actually states this information. This talks about how to file those waivers to extend the timely filing limit. I mentioned to you that there's certain things that you need to submit to our claims manager. And that information is all here for you. And of course, then there would be an address listed. I'm out on the J8 Mac B. See how this is dark blue up at the top, J8 Mac Part B. If I wanted the J5 Mac Part B information, I'd simply click over here, and then I have the addresses for J5 Part B. All right. Proper billing of various Medicare Advantage HMO claims. This just talks about claim submission for your beneficiaries that have a Medicare Advantage plan. The coverage database is here if you want to look up a national coverage determination or any local coverage determination. This is a searchable national depository of information. The CMS maintains this on their website, and they've also published a great tool called How to Use the Medicare Coverage Database that you can look at here as well. I've included a link to the Beneficiary Notice Initiative webpage. That's helpful for those situations where you want to present your patient with an ABN in advance because of the likelihood that a service you're billing may be denied due to medical necessity or frequency. Incarcerated Medicare beneficiaries, I had that trending piece in this presentation, so I wanted to provide you a link to that webpage. There's information. Whoops, got ahead of myself here. Apologize for that. Sometimes I hit the scroll button on my mouse. National Correct Coding Initiative webpage. Here's where you will find those edits for procedure to procedure. So if something is bundling, this is where you'd want to come, or denying for bundling reasons. And also the Medicare unlikely edits. Those are those situations where the units of service are in excess of the MUE. So this provides for you those edit tables. Here is some information about our IVR, the interactive voice response, available 24 hours a day, 7 days a week, but there is limited functionality outside of normal business hours. Here's where you can check eligibility, claim status, and other details. This, of course, is the tool you use your voice or telephone keypad for using this. We have an IVR operating guide that tells you how to use the IVR. Similarly, you could check eligibility, claim status, claim details, and claim actions, but there's a more info button on our transactional portal. If you're viewing claim details, there's a button that appears. It says more info. If you click on that, you will get more information about your denial. So for example, let's say a claim line denied due to a policy. If you click the more info button, it will present a link to that policy. So you can actually see right then and there why your claim denied. So this tool, 24 hours a day, 7 days a week, like the IVR, but limited functionality outside normal business hours, is very helpful. I did tell you that I would show you where you can find a link to our manual for the transactional portal. If you're out on any page of WPS's website, and I can click around anywhere on WPS's website, go to the home page, or go to any topic center, every single page on our website has the login to use the transactional portal, and right below the box that says login is a link to that portal user manual that has those instructions and illustrations in it. All right, let's go here. We are right at 10:59, so I do not have time to take live questions now, and I apologize for that, but please don't worry. In just a couple of minutes, I will tell you how you can submit those questions to me 1 week. Greatest compliment we could ever have is for you to recommend our education to others. So we ask you to do that as you're out and about or talking with those within your organization. This really does assure current and effective education for everyone in J5 and J8. On behalf of myself and Ellen and our entire provider outreach and education unit, I want to thank you for participating today. We look forward to those survey comments, and we hope to have you join us at future events. You may now disconnect.